Thank you, Klaus. Nice to be back. I hope it's okay I do this in English. I think we often have an international audience. So we're from Targovax. At Targovax, we're developing oncolytic viruses. And oncolytic viruses we see as an important immune activator class to complement other drugs, such as checkpoint inhibitors and chemotherapy. That's the focus of Targovax. Our lead program is called ONCOS. ONCOS is an adenovirus. It's genetically engineered to selectively infect and replicate in cancer cells. The whole mode of action here is to try and turn cold tumors hot so that they become susceptible to respond to other forms of treatment, such as checkpoint inhibitors. We don't see them necessarily as promising agents as monotherapy, but rather as parts of future cocktails in various types of cancer. Having said that, we've still done a single agent trial. We've completed a phase 1 where we used only the virus in order to tease out the activity of the virus in itself. But now we're running a clinical program with 4 different trials, which are all combination trials, both with checkpoint inhibitors and chemotherapy. In total to date, we have treated more than 150 patients, which makes us relatively advanced. I'd say one of the top 5 leading companies in the oncolytic virus space today. Before, we used to have another program here, a pipeline program called TG, which was a mutant RAS targeting vaccine. We had developed 2 programs to the phase 2 stage, and we're planning to sort of go into randomized clinical trials. And now we have decided to exclusively focus on our oncolytic virus program. It's simply too resource demanding to pull 2 programs forward towards a later stage development. So we announced last week that we're now focusing our efforts 100% into the ONCOS program and delivering the news flow readouts from our ongoing trials over the next 1 to 2 years. So with ONCOS 102 is our lead clinical product. These light blue boxes are trials that are completed. We ran a compassionate use program and then a phase 1 trial with 12 patients. I'll show you some of those data. And now we have 2 ongoing trials which are sponsored by Targovax. The top one here is mesothelioma. This is our path to market, our lead indication. This is a 31 patient randomized trial. And then we're doing a second trial in melanoma. This trial is fully enrolled. We're expecting data around New Year 2020. This trial here has 2 dosing cohorts. The first dosing cohort is fully enrolled. We're releasing data on those this summer, and then the second cohort will have data next year. In addition, we're running 2 trials with collaboration partners. So these are trials sponsored by someone else where we supply the drug. One's in ovarian and colorectal cancer that has spread to the peritoneum. This is up to 78 patients. We're doing this together with CRI and AstraZeneca. And the final one is in prostate cancer, where we're combining with a dendritic cell vaccine. So I'll show you some of the highlights from our phase 1 trial. This is important because this is single agent data, so it shows you what the virus does on itself. This was heavily pretreated patients, 7 different solid tumors. And what we saw here was that when we scored the increase in T cells infiltrating the tumor against overall survival, you get this very neat correlation. So the better the immune activation, the larger the infiltration of T cells, the longer the patients lived. And at this time, and I think still this is quite remarkable immune marker data from an oncolytic virus that really hasn't been shown by many other viruses. We had some very interesting patients in this trial. This top one was a lady with ovarian cancer who stabilized for 3 years and lived for 3.5 years with no other treatments. And she had more than 1,000-fold increase in T cells in her tumor. And the second patient down was a mesothelioma patient who also had a profound immune response, stabilized, lived for 18 months, even though it was essentially a last-line patient with no other options left. So these were particularly interesting, and we chose to move on in ovarian and mesothelioma based on this. In fact, of the top 5, 2 were ovarian cancer and 2 were mesothelioma. So let me show you the 2 mesothelioma patients we had in this trial. Both had a profound increase in CD8 count in the tumor. You can see the staining here from baseline to week 5 goes from essentially zero detection of T cells to penetration basically throughout the lesion. We also saw increase in CD4 cells in the tumor, as well as an increase in PD-L1 expression. And this is important because PD-L1 is becoming a more and more important marker to predict whether patients will respond to checkpoint inhibitor treatment. So it's looking like we're taking patients that might not be eligible for checkpoint therapy or unlikely to respond up to a level where they're likely to actually have a benefit from a checkpoint treatment. So based on that, we started this trial here. It's randomized 2-to-1, 31 patients. Here we're combining with standard of care chemotherapy. So these patients are getting a combination of pemetrexed and cisplatin chemo, and we simply add the virus on top and we compare to the chemo alone. This is the design of the trial. We had a safety lead-in cohort of 6 patients, simply because this is the first time we combined our virus with chemotherapy. That was completed successfully with no concerns. We reported that, I think, here, actually, at the Pre-ASCO seminar last year. Now I'm pleased to say that the experimental part of the trial is fully enrolled as of a few weeks. So now we're waiting 6 months to get the ORR data and analyze those, and we'll have those ready late December or early January timeframe. To quickly illustrate what we've seen so far, as I mentioned, safety. This is from the first 6 patients, the summary. Safety was no concern, no added toxicity beyond what you expect from the chemotherapy alone. We saw systemic increase in pro-inflammatory cytokines, interferon gamma, TNF-alpha, indicating that we're generating a robust Th1 type immune response in these patients. 3 out of 4 patients where we had tumor biopsy material have increase in CD8s into the lesion, and we're also able to importantly identify tumor-specific T cells that recognize and infiltrate into the tumor in 2 out of these patients. So this is important proof of the mechanism that we're proposing. Of these 6 patients, we had 50% that stabilized, 1 PR. This is sort of in line with what you expect to see, but it's hard to make any judgment on that based on the low patient numbers. But of course, we're very curious to see how the randomized part of the trial turns out. So we consider mesothelioma our path to market simply because there is very little going on apart from a few checkpoint inhibitor trials. This is really an orphan indication with just 1 chemotherapy that is approved. So there's a chance to become a standard frontline treatment. We have orphan drug status in mesothelioma. And as I said, very limited competition. So overall, we think this is a niche where Targovax can develop the virus and get it to market. We think that's a better strategy than going after maybe bigger but much more competitive indications. So I wrap up by showing our pipeline. On top here, the phase 2 in mesothelioma. We expect the data early or January sort of next year. We're already making or preparing for what will happen after this trial. So we're discussing different study concepts to follow up on this trial. We're actively speaking to KOLs and figuring out exactly what is the best combination and best patient population, and we'll update on that going forward. In melanoma, we expect data from our first dosing cohort, which is 9 patients, in July, and then we'll have the full trial, which will be 21 patients, probably about a year from now or so. These other 2 trials we're not formally guiding on timelines. These will be updated by our collaborators, so we're a little bit at a distance there. Also at the end, I'll mention we have just filed IP for our 3 new viruses. So these are 3 new constructs based on the ONCOS-102 backbone, where we insert double transgenes. We're currently doing in vivo work to investigate the mechanism and effect of these, and we'll update with preclinical data second half of the year. So with that, I wrap up, and I'm sure Klaus has some questions.
Yeah, thank you very much, Erik.